All right, so today we're going to revisit asthma, and this is going to pick up where the previous lecture left off. That was back in Foundations of Medicine. And so I just want you to review, and I'm actually going to review them for you, the inhaled beta-2 agonist, as well as the antimuscarinics, or sometimes referred to the anticholinergics, as well as the inhaled corticosteroids from the first asthma case. And then today we're going to really talk about the immune-modifying drugs that can be used in asthma. Okay, here's your learning objectives, and these are all the drug classes we're going to go through. Excuse me. And we're going to talk about an important pharmacology concept called the therapeutic index, and we will talk about some of the unique pharmacokinetic properties of inhaled drugs. All right, so here's kind of the drug list. I've broken it up into kind of two different groups. Here you've got your mechanical type drugs, and so these are the drugs that basically kind of open the airway and mechanically kind of rescue the process of bronchoconstriction. These are the drugs that are your immune targeting drugs, and so all of these different pharmacologic targets basically kind of inhibit the pathogenic processes that contribute to asthma progression. All right, so let's briefly review. These are the mechanical drugs, and this is my own kind of distinction. This isn't one that's listed in the textbook. So this is kind of how I think about them. And these are the beta-2 agonists, or the muscarinic 3 or cholinergic antagonist. All right. Excuse me. And so what they're going to do here is we're going to see a relaxation of the smooth muscle that surrounds the bronchi. And we're going to inhibit the release of some of these bronchoconstricting mediators that come from mast cells. So it's kind of a twofold mechanistic approach, but really when you talk about your beta-2 agonist, you're really thinking of this really potent smooth muscle relaxation. Okay, and this is going to occur by way of stimulation of adenylyl cyclase, and this is going to increase the amounts of cyclic AMP within the smooth muscle. And here you'll see bronchodilation within about 10 to 15 minutes of the inhalation of any of these drugs. Excuse me. And the clinical outcome is going to persist anywhere for 3 to 4 hours for the short-acting beta agonist, the SABA, or the much longer-acting beta agonist for 10 to 12 hours. Okay, and so the short-acting ones are kind of for quick relief of asthmatic symptoms. Albuterol, sometimes called salbuterol, is kind of like the prototype. And these are all these different derivatives of albuterol listed here. This is all through inhalation. Albuterol and terbutaline can also be administered in a tablet formation. This is kind of more for like severe asthma. We'll talk about that later. And then terbutaline has also been formulated to have a subcutaneous injection formulation as well. So these are your short-acting beta-2 agonists, and the majority of which are inhaled. Your long-acting ones, which last up to 12 hours, most often not used as a monotherapy. They're used as kind of an add-on therapy for the control of asthma. And you see them sometimes used in combination with ICS, or inhaled corticosteroids. And this is kind of for long-term prevention of symptoms in patients that have, moderate to severe but persistent asthma. All right, and then some of this criteria is listed here. Excuse me. And this is based on practice guidelines from the FDA. Okay, the prototype here is salmeterol. Of course, formoterol is also within that same category of long-acting beta agonists. And just as a small point, salmeterol is a partial agonist, and formoterol is a full agonist. Okay. Oh, sorry, backwards. And then the other group of drugs are your anticholinergics, or your antimuscarinics. And so these drugs inhibit the muscarinic cholinergic receptors that typically can bind to atropine, and they're going to reduce the vagal tone within the airway. And so remember, there's opposing effects of norepinephrine and acetylcholine, and so these are going to inhibit the acetylcholinergic type of effects. Okay, some of these patients that have a really strong or really prolific acetylcholinergic response, and some have less, and so that's why these drugs can be pretty helpful. So these are antagonists of that smooth muscle M3 receptor, and the prototype here is ipratropium bromide. Okay, and it actually can be used with a short-acting beta agonist in patients that have moderate to severe asthma that experience exacerbations. Um, and then the other one that's listed is tiotropium, which is a little bit longer acting. So this is kind of a really quick kind of summary diagram of the opposing forces that basically can produce bronchodilation. We can do beta-2 receptor agonists to promote smooth muscle relaxation, or we could do M3 receptor antagonists to inhibit smooth muscle contraction, which would thereby promote relaxation. Okay, so that's kind of a brief summary of the mechanical portions of the drugs, and then now we're going to go into the immune targeting or the immune modifying portions.